everyone. Thank you so much for joining us today for the TEPHI Infection Prevention and Control webinar series, Module 206, Emerging Infectious Diseases. For the Houston area and everyone affected by Texas, we hope that you all are safe and sound and have hopefully that everyone that has lost power will have that restored soon. So just welcome again. Feel free to post any questions throughout the presentation in the chat at the end of the module. When we get through the lecture, we will have a learning activity to gauge your understanding, and then we'll open it up for questions. These modules are recorded, and within a week, you will get a link to the recording along with a slide deck. So the slides will be posted, will be emailed to you in a recording along with the recording of the video presentation. And today we're going to talk about, give a brief introduction about emerging infectious diseases, specifically looking at Mpox, C. auris, and H5N1. This lecture has been approved for 1 hour of continuing education for a certified public health professional, your CPH, or if you are a certified infection preventionist with a CIC, 1 hour of a PUI has been, an IPU has been determined for this lecture. So before we get into the lecture, we just want to briefly tell you what TEPHI is. TEPHI, or the Texas Epidemic Public Health Institution, is a state organization that has been housed here in Houston at the School of Public Health, and its goals are to keep Texas safe and the Texas economy strong by increasing its capacity and resilience for Texas communities so that we're better prepared for future infectious disease outbreaks. My name is Kayla Rush, and I will be today's presenter. I'm an infection prevention practitioner who is certified in public health, healthcare accreditation process, and infection prevention and control. I hold a CIC. During the pandemic, I had the opportunity to work as a IP here in Texas in acute care, and then I went out to New York in 2020 and worked in long-term and nursing home there before I went back to acute care in California before returning to UT Health to pursue my PhD in epidemiology with a focus on infection prevention, training, and education. So today's learning objectives is that we're going to describe Mpox and talk about good IPC practices. Same with, we're going to briefly talk about C. auris and describe ICP practices, and talk about H5N1 and describe some IPC practices. So this is just a quick, brief overview of current, up-to-date recommendations, our state-specific PUI forms, or person under investigation forms that we'll talk about, and then the current infection prevention practices and guidelines that either DSHS or CDC are currently recommended for these 3 pathogens. So let's first get into Mpox. So Mpox outbreak kind of started back in 2022 here in the United States, and in the last few years we've seen an increased case count, and then going into 24 we saw a very sharp decline in case count. However, in some of Texas regions, for example, region 5 and 6 in the Houston area, we have seen an increase in case counts in Mpox in the last month. So really showing that this pathogen, yes, had increased incidence back in 22, but we're still seeing waves and pockets and cluster events of this pathogen. So Mpox can be transmitted through zoonotic, so animal to human and then person to person. Its incubation period is a range from 2 days to 21 days, so a long period, kind of like how we saw with COVID. And we do have a laboratory testing, PCR, and specific genomic sequencing that we can do. You can work with your local health department or DSHS to get specific genome sequencing, which is a requirement if you have an Mpox positive test. But you always want to make sure that if you are thinking about that, and you get that result, if you use that commercial test that's from Roush or another factor and it's done in your facility, when you get those positive test results, you are calling that in and you are talking to your local or state health department. They're wanting to send additional isolates for genetic sequencing with that too. So definitely making sure that you're collaborating if you do not go through them the first round to do laboratory testing, you're using your private lab within your facility with your PCR, or if you're using a third party such as LabCorp or Quest. So Mpox really affects people in a different range. The normal, healthy, immune competent individuals, it's very mild symptoms. You'll see fever, fatigue, headache, pain, kind of flu-like symptoms. But the biggest one that you'll see is a rash, and this rash can present in many different ways, from maculas to pustules to vesicles to scabs to crust, and these lesions are very deep-seated as well. They can be very painful. A person can have a wide range of lesions. It could be one or it could be over 100, and it really just depends on their immune susceptibility. If they're immune compromised, which we see in some of our older pregnant children, our HIV patients, you're going to see more lesions throughout the body with other factors that you can see here. This was a nice graphic that was in a Nature article cited below, with just being able to determine how symptoms are presenting based on their immune status and severity. And here's a great graphic to really show the different levels of how the rash can look in the different stages. So as we talked about that incubation period of 2 to 21 days, you'll see a lot of different ways that the rash is presenting, first as macules, then to papules, to vesicles, to pustules, to crusting, and then heal. And you can see on this lovely graphic of the different stages, which is really great. It's always, for me personally, it's always great to have a graphic of the rash so you can educate your providers, especially in your EDs, your urgent cares, your outpatient clinics, of like, hey, this is the rash that we are looking for. Because I know rash explaining and documentation can be very subjective depending on your clinician or your provider that's seeing the patient. So having a standardized workup of what exactly you're looking at and properly educating your staff of this is the rash and these are the stages of the rash is really helpful to properly identifying these patients so that we can put them in isolation, we can have good follow-up, we can contact our local or state public health authorities and let them know that, hey, potentially this patient might have Mpox, we need to track and follow them and ask them those EpiLink questions. So for Mpox screening, so now that we know these patients are presenting usually with mild flu-like symptoms and then a specific rash, that's really who we're looking at, can be very vague. A lot of viruses present with lots of different types of rashes, so definitely assessing the rash and doing a skin assessment is very key to identifying these patients in a very timely manner. And then also asking, it can be, for your question, it can be anywhere. It can be on the feet, it can be on the hands, it can be on the mouth, it can be on the groin. The rash can present anywhere. So make sure that when you are providing that information to your providers, you're not just giving a specific region of the body that they should be assessing. They should be doing a head to toes skin assessment of what kind of rash and where it can be at. But that's an excellent question. So you're having these patients present usually in urgent cares, outpatients, or freestanding ED a lot of the times because this isn't as severe of a disease unless they are very immune compromised. They aren't really getting admitted to the inpatient side. A lot of this will be seen on the outpatient side. But making sure that we know who we're looking for and then asking them specific questions. And then when patients are coming in with this rash and flu-like symptoms, your providers are aware during triage of asking them, hey, have you come into contact or a known contact with someone that has Mpox, or have you been in a social event where someone else had this rash, and you're really asking those epi links to understand if this is a cluster event or if this is an isolated event, especially that these are mild and moderate symptoms. So when you're assessing people with Mpox, you want to, this is what dishes and CDC recommend for PPE. Anytime with a rash, you want to make sure that you have gown, gloves, and masks. They are recommending the NIOSH approved respirator, or an N95 filter higher, or your PAPR, and then eye protection as well. So if you need help with that donning and doffing, you can look back to our infection prevention module 101. We go through of how to properly don and doff PPE appropriately, and always remember that hand hygiene is performed before and after. Next, when you see a patient come in with potential Mpox, or because of the rash and the flu-like symptoms, Mpox is in the differential, you want to place them in a single room. There is no specific air exchange. However, if this is a critically ill patient, very immune compromised, and you might have to do anything relating any respiratory procedures, intubation, extubation, you want to make sure that that is performed in negative pressure, and that N95 or PAPR is for surely worn to reduce exposure to your healthcare team that is providing care. Single room, no special air exchange, so neutral air, door closed, and then also with any infectious disease pathogen, you always want to minimize transportation, or if you can have that be the last case of the day, and go to single-use items such as like blood pressure cups, stethoscopes, anything like that that really helps reduce your cross-contamination rate and potential exposure to other healthcare staff and patients. If you do have to transfer the patient, say that they're critically ill, they have these rashes and lesions, you want to make sure when they're transferring that all lesions, especially if they're open, oozing, are always covered, and that's good infection prevention practice for any lesion, any time of transportation. You want to make sure that's covered, clean and dry covering, and then that patient also is placed with a surgical mask. And remember, N95s cannot be issued to patients. It requires a fit test. So you should never be providing an N95 to someone that hasn't undergone a fit test, so they know what size and seal, because that can result into a respiratory event since they're not used to wearing them. So always just a surgical mask, properly, snug to the face, over the nose and mouth during transportation to reduce exposure. For disinfectant for this, you want to use that EPA list Q, which is that quad ammonia-based chemicals. Make sure you become very familiar with the chemicals that you're using in your facility. You can always look on the specific label of what it is effective. It's a fungal side, which means it kills fungus. If it's viral side, if it kills viruses, bacterial side. Anytime side means death, killing, and static means like preventing or inhibit growth. So always just look at your chemicals that you're using, make sure that you know what you're using is effective to the pathogen, that you're doing your workup, and that you are maintaining proper wet time, which is that whole surface remains wet for that specific time indicated for the product to be affected. So if it says a wet time or contact time of 2 minutes, that means that surface that you are cleaning needs to be wet for that whole 2 minutes before it starts evaporating. You want to use the wet cleaning method, meaning that like you want to spray down and not kind of like do anything that will pick up dust and throw different particulates up into the air. And then specifically like with soiled laundry, if you're stripping a patient's bed that might have been worked up for Mpox, especially specifically with any patient that has rashes or lesions that are open and weedy, you don't ever want to shake that bedding. You always want to make sure that you're folding it away from your scrubs in your body and then putting it in those soiled laundry bag to really maintain good IPC practices, and that you're not having crossover exposure due to putting the contaminated sheets on the floor or not bagging them appropriately. so that you're not increasing the infectious droplets being spread to different areas. So next, we're going to go over the current Mpox dishes reporting form. So this is our state Texas-specific IP reporting form that we should be using and reporting with anyone that has Mpox. It's always great if, as best practice, to give your local health department, if you're seeing this type of patient, especially that we've had an uptake in the last month, 2 months of patients having higher incidence of this, we want to, kind of give them a heads up that this is a potential patient that we are thinking about doing this. And so that if they need another set of swabs set in right away, you can collect that and compared to running your own assay on using your lab and then or a private third-party lab to really help expedite making sure that samples are not lost and they're collected, so that you're not missing the opportunity to do genetic sequencing specifically on them. So the first section of the reporting page, and all of these are in the resource, the 3 reporting forms that I'm going to go over today are all in the resource reference links below, and then they're cited as well. So this link will take you to the Texas Dishes Reporting PUI or Person Investigation form. So the first one of the clinical presentation, always asking date of onset, are they going to be hospitalized, what facility, and then making sure that you look at all their symptomology and reporting, kind of to provide public health with a very clear picture. And then as you see here that they're asking specific date of onset of rash and where did the rash appear. And to the previous question, it's asking where on the body it is. So it has a very wide range. So don't tell your providers just to look at like it's isolated to hands and feet. It can be all over depending on your patient, so that you're marking appropriately where the rash is and then what type of rash it is. And referring back to that, that graphic that I showed on a few slides before, really documenting what type of rash it is and then how many lesions do they have. And you can see here on the form, it is even reported that some patients will have over 100 different lesions, and then ask what stages are the rashes are in, and going through a lot of details specifically about the rash. And then this is, I wanted to highlight this point that public health was really asking for pictures to help characterize the lesions and the development and distribution. So if you can take pictures of what the rash looks like, it can also help with confirming the diagnosis and then, making sure that we are properly identifying our rashes as well. So that's the first section of the form. And then the second one talks about those epidemiology exposures. So they're specifically asking for your epi links in the last 21 days before symptom onset. So symptom onset would be day 1, and then going back 21 days, so minus 21 days. Have they had close contact with anyone that is a confirmed Mpox case or that is being worked up for an Mpox case? Have they had contact with 1 or more persons with similar symptoms? Have they had contact with any exotic pets or animals? Since it's zoonotic, it can be from animal to human. That's why they're asking that question. And then also asking about sexual encounters and making sure that you're having that very open, transparent conversation, and then really working with your patient and your providers to be able to have an open conversation to see really who's at risk and what types of other people that might be at risk due to sexual encounters. And then always having those very sensitive conversations, very open and neutral, and reassuring that there's no judgment or stigma or anything when you're asking about that this is really a public health issue. We're trying to identify, we're here to help them, provide medication and treatment, and then just reduce the spread of transmission of an infectious agent. And then it asks you specifically about travel history, where have you been, flight numbers, seat numbers, etc. And then lastly, it'll ask you for your ill contact. So if that person says that they have been in contact with someone with some similar symptoms, then you're listing them under your ill contact, so that public health can then do that contact trace and follow out with them on the outpatient side. And then specifically what type of contact did they have with that patient, and it lists you here. And then if none of these describe that type of relationship that patient had with someone, the marking down other and kind of explaining in a very concise way of what type of relationship they've had. Treatment is, our current treatment for Mpox is TPOX, which is FDA approved. And to get this, you are going to work with your local health department and the state health department to get this medication. They can go through the STOP initiative oral treatment, or they can also go through the CDC IND protocol to get this as well, because it's not available yet. But if you're a patient, this is why giving your local public health a call when you're having this patient come in to kind of expedite of getting this medication if the patient is seeking it or wanting to it as well. So that's why it's important when you think that you have an Mpox patient under your differential in your workup that you're calling them right away, so that we make sure that we are collecting the right type of swabs, so there's not a delay in swab collection or a missed opportunity to collect swabs, and then also that we can expedite getting them treatment if that's what they're seeking. And then for prevention for Texas, we're doing the Junos. There's 2-dose series, 28 days apart. And then for prevention to reduce risk of having this exposure for certain individuals, and you can work with your local health department as well to know more about how to obtain this. And then following good infection prevention practices of, if you have an ill person that is under the differential or you're suspected to be Mpox, they're isolating at home, they're wearing a mask, they're covering their lesions, they're engaging in safe sex practices. If they go out in public, all of our lesions are covered, and then they're wearing a mask, especially that we have flu-like symptoms as well. So trying to reduce the spread, and of course, really good hand hygiene. So now we're going to go into the next one, which is Candida auris. And as we know, we're starting to see an uptake of Candida auris, which is a fungal pathogen. It is a fungus, Candida subspecies, and we're starting to see pockets all over the United States. We kind of started seeing this pathogen emerge back in 2019, 2020, before the pandemic, and there was a lot of CDC on alerts before the pandemic, and then it's kind of gone on the wayside in 20 and 21. Due to just COVID kind of taking over. And now we're kind of seeing the aftermath of this, that we're starting to have more incidences of these certain cases around the country. It is highly transmissible. You have person to person, and then you have secondary contact with affected service. Since it is a fungus, it's really hard to treat and kill. So making sure that you're identifying these patients right away, because this fungus can survive on surfaces for a very long time. You can do PCR with them in cultures within our specific within your specific laboratory. We're able to specifically isolate, and then also being able to have that conversation with staff of what subspecies of Candida, not Candida albicans, which is a common yeast that we see. That one is not as concerning, it's Candida auris. So being able to communicate that to your providers, that it's a specific strain that we need to be concerned about and initiate, not all different types of species of Candida. So most of the time, these patients are usually colonized and they're being admitted for something else. This is not the primary reason why they are being admitted, but sometimes they will have fever, chills, low blood pressure, very kind of like mild specific symptoms, but these are more that the patient potentially was having a heart event, a cardiac event, chest pain, they're critically ill, and there are some other issues that they're admitting for. Usually a Candida workup isn't your primary admission workup, but it's something that we need to now be seeing, especially that we're starting to identify certain patient populations that are at higher risk of being colonized, and so that we are properly tracking them especially when they come into our facilities, that we're initiating good screening and then isolation practices and then good disinfection practices to reduce the spread. So people that are likely to have colonized with Candida is that they can have medical devices, like people that come in that have been in ventilators, and these are these critically ill patients and they've had prolonged stays at other healthcare facilities. They're coming from a long-term care or from a nursing home facility as well. When you're screening these patients, when they're coming into triage, always asking them, where have you come from? Are you a known Candida auris facility? Has there been an outbreak? Do you have anyone in the home that is a known C. auris patient? Also, CDC recommends that if they have an MDR-Row, a multi-drug resistant gram-negative bacteria that has received healthcare outside of the United States in the last 12 months, that you consider screening them for Candida as well. And the recommendation for screening of Candida is doing a composite of axilla and groin, which is your armpit, and then your inner thigh. If they also have a urinary catheter and nephroscopy tubes, it's great to get a urine sample as well to run a culture on that, since they become those systems that urogenital tract can be colonized with Candida. So you want to make sure that you're doing that as well. So a composite, you'll start with swab, as you see pictured here. You'll first do the axilla, the armpit, and then you'll use that same swab and you'll do the groin. And that's what it means when it says a composite culture. Next, for then PPE with these patients, you are triaging them, you are asking them where they come from, those risk factors that we just talked about, and they screen yes for one, they come from a known Candida facility. You want to initiate isolation precautions immediately, which is extensive contact precautions. So these are gowns, our gloves, our face shields, our masks. We're doing really good compliance with hand hygiene with soap and water and alcohol-based products, and then moving to single-use items in all ways possible. As I mentioned before, this is a fungus. It is really hard to disinfect and remove. So if you can reduce having to disinfect these items and just remove them through biohazard trash, that will reduce the risk of cross-contamination as well. So definitely, having them in a specific room with isolation. It's well documented in their chart that they're being screened for Candida, and you're initiating those precautions during the screening process. If after you screen them, obtain this culture and the culture grows out negative, you can remove those precautions, but refer back to your policy specifically in your facility of what the recommendations are. If you're keeping them because they have some of those risk factors for Candida, or if you're clear to remove them. So refer back to your specific policies. For patient placement, you always want them in a single room, minimize transportation. If they have to be transferred for other workup of going to imaging or a procedure, try to have them as last case of the day, because you will do a terminal clean in whatever room that is. So definitely letting your EVS workers know of, hey, we have a patient being ruled out for Candida. They have epi risk factors. We're going to schedule out them the last of the day. This room has to have a terminal clean. So any room that they go to, you're going to have to do that. So making sure that you plan that and you talk to your other counterparts that this is a multidisciplinary collective of EVS to transport to whatever service line that they're going to, so that we're not delaying care, and we're making sure that we're using good resource management. If you're in a more congregate setting, such as like a nursing home or long-term care, you can consider grouping your patients together in Candida rooms or units, but you always want to try to decrease movement, decrease equipment sharing in non-effective areas, or have a high infectious area and low infectious, and kind of looking at your different zones, and then cleaning and disinfecting each bed in separate areas, and then using privacy curtains as well in those big communal spaces. And then with the curtains, removing them, and letting them know, letting EVS or facilities take them down and letting them know, hey, this was in a Candida room. When you're taking down the curtains, you need to be in PPE, and then they need to be laundered a specific way. So having that clear communication with all your staff members that are in this area is really key to reducing a potential outbreak in your facility. For disinfectant, it is going to be EPA List P, which is more of your hydrogen peroxide or your sodium hypochloride. If you do not have those products available, then you are going to use your List K, which is your C. diff spores, but that bleach. Using bleach and hydrogen peroxide is the recommended. Making sure that you're following the proper contact time. And then specifically, I wanted to note those ammonium quat, those products are not effective, so do not use them. But making sure, again, that you are reading your specific label on the disinfectant that you're using, you know that wet time, you are maintaining that wet time, and then cutting down to single-use items and anywhere possible to reduce disinfection and cross-contamination and spread of this pathogen. So our state requires us to report results to them within 1 working day, and then this is the state form for Candida investigations and outbreak. So you see in public health use, you have your first column, your patient's names, your demographics about them, what specific region that they're in as well. And then going through like what source, who's reporting it, the reporting provider, all of that as well. Next, you will fill out your hospital facility information, what hospital is this patient admitted to? Are they from a previous hospital or a healthcare facility, such as are they from a nursing home or an LTAC coming into acute care? Are they in acute care going to a nursing home or an LTAC? Knowing kind of the transportation route, where are they being discharged, if it's an acute care, where all of that, and then the name of the facility, and then making sure that you are notifying the facility, especially if you are discharging them, that during your facility transfer to transfer information, that you are specifically informing them that, hey, this is an MDRO and this is MDRO Candida auris. That is very important information to know, so that when that patient gets there, the facility already knows, hey, this is someone that needs to be placed in an isolated single patient room with isolation measures already implemented. Next, then other diagnosis about certain onset, asking about travel and healthcare, were they outside of another country receiving healthcare, that screening factor, that risk factor that I previously stated, asking here. And then laboratory data too, of like they're wanting to do specific sequencing again on this as well. And so it goes through here, what type of testing. And if you're not quite sure, definitely talking to your local public health agent, calling them and letting them know, hey, I have a Candida positive lab test result, I'm not quite sure. Definitely just working with them. There really are ally partners, that it is a collaboration. We're here to make sure that, you know, together that we work on identifying these infectious patients, they aren't lost to follow up, and that they're being tracked either in the next facility or if they're out in the community too, to reduce the spread. And then lastly, looking at specifically their previous history and then their exposure history too, of how did they, do we have information to know of how they came in contact with Candida. For treatment, we can give a lot of antifungals. That's pretty common as our standard of care. We can also, if it is an resistant antifungal, we can do other things or do a combination treatment. Definitely let the infectious disease physician provider know. They can make the best plan of care, and definitely looking at that MIC results with all your cultures of telling them, hey, it is resistant. It's not what you think, how is effective, because this treatment sometimes is a very long process. So definitely that, you know, someone is following and tracking them for treatment as well. So prevention, the best ways to have prevention in your facility is have a good screening protocol that when patients are coming in for triage in any areas, or if it's a direct admit, you know specifically, are they coming from an MDRO facility? If yes, what MDRO do they have so that you can properly put them in the right single patient bedroom from the beginning and start good IPC practices from the start, or if they're coming through an urgent care or a ED, that you're asking those questions of not only symptomology of what they're currently experiencing, but where are they coming from, especially if they're brought in by ambulance, definitely asking our EMS providers of where exactly did they come from, what was the report given when they picked up, so that we're all properly communicating and working together, and then providing that education to staff members of, hey, this is a specific Candida that we are looking for. It's not the same, such as Candida albicans or Epidis. Any of those, we don't, those are not high priority compared to Candida auris. And then that we are implementing good IPC practices right away. It's easier to implement isolation, obtain cultures from the beginning if you think that this is in the differential, compared to waiting a day or two, then having to do a contact trace, an outbreak, and potential spread and cross-contamination to other healthcare providers and other patients. So when in doubt, being overly cautious with patients is the best way in prevention. So then the next one we're going to go over is the emerging pathogen H5N1, or bird flu or avian flu, that a lot of us have seen. And this pathogen has been seen in multiple zoonotic species. A lot of our wild birds, our poultry, our dairy cows have been the highest animal species that we've been tracking and trending. These numbers, as you've seen, were pulled from a couple weeks ago from the CDC, how they are monitoring this emerging pathogen. Specifically for our human case counts, and here's our technical report, the sites underneath of it, we've had 3 human cases confirmed for H5N1. We've had here 1 in Texas, as you can see with their genetic sequencing as well, and the patient main primary symptom was conjunctivitis, really having gucky, like mucousy, watery eyes. And then we've had 2 other people confirmed in Michigan, 1 with conjunctivitis and 1 with upper respiratory symptoms as well, and they've all been exposed to dairy cows. So this, as of right now, the current guidelines really show the epi link to occupational exposure and close contact with infected animals. So that's kind of who we're looking for with this pathogen. A lot of the symptoms, again, are flu-like symptoms, upper and lower respiratory as well. And so it's that mild, low level. So when people are coming in with flu-like symptoms, definitely asking them, what do you do for an occupation, and have you been exposed to any sick or deceased animals in the last recent days, weeks, to try to identify potential H5N1 individuals. So that's definitely the big question that we need to be asking when people are coming in currently to any of our healthcare facilities right now and they're presenting with flu-like symptoms, even if they are mild. What do you do for an occupation? Have you been around any sick animals? So if you have someone that's coming in with flu-like symptoms, hopefully that we're still providing them with a surgical mask, and then we're asking them those epi-link questions, specifically a comprehensive medical history of where have you been in the last 21 days? What is your occupational hazard, such as occupational hazards and occupation? What do you do for a living? Illness contacts, and then also including ill wildlife or pets, anything, because you can get it from a wide range of species can be affected with this pathogen. And then making sure that we are sending all specimens to the lab. We are doing rapid respiratory panels, and then if we think that someone has answered yes to well, I work on a dairy farm, I now have flu-like symptoms, you're contacting your local health department immediately so that they can tell you next steps of getting a specific sample. Since right now there's no commercially available assays, we're going through our local and state health departments for identification. Compared to Mpox and Candida Auris, we are having third-party approval. We can go through our independent labs, or if you use a third-party labs, as I mentioned before, such as Quest or LabCorp. This one, since it isn't a very emerging pathogen, we need to contact them immediately so that we know what specimens to collect, how to collect them, how to send them, that their lab is open, they're receiving samples, and that we've ruled out other upper respiratory or influenza-like illnesses, such as we're doing our influenza A/B panel, we're doing our COVID and our RSV. So I know this is a lot of information, but this is the current CDC epidemiology criteria of June of 24 on the CDC site, specifically looking at recent exposures. So if you have someone that has been recently exposed to this pathogen, as you see here, close contact, so they're still using that common definition of close contact being within 6 feet of birds or other animals that have been confirmed with this virus in all process, or direct contact with surfaces contaminated with feces, unpastured or raw milk, or have been visiting a live bird market, confirmed bird infection as well. So you're looking at who exactly has been specifically exposed to this highly pathogenic avian flu, the HPAI, if you see that for H1N5, and then looking how they're defining exposure to an infected person as well. So they're saying for that being close contact within that 6 feet unprotected, so no mask or eye protection, who has been in close contact within 5 feet of someone that has been confirmed probable or symptomatic for the specific. So a household contact, an occupational contact, so a coworker, or if you've been within the healthcare facility. So the current recommendation for PPE on people that are PUIs or while working with people on PUIs is that you are wearing your mask, your eye protection, your gown. If we're collecting any samples, of course, using gloves as well. We're having single patient placement room, and right now the current CDC guidelines is that they're contact and airborne precautions. So putting in that negative pressure single room. If no negative pressure is available, then you are putting them in a single room with neutral air closed as a backup. So kind of the same recommendations that we said with COVID, of making sure that we are wearing the proper PPE for this pathogen. For laboratory testing, that we are doing that PCR, and as I mentioned before, making sure that you're contacting your local public health agency within your jurisdiction to ask them what type of swabs that we're setting, so we know what swabs, what transport media, we have the correct form to fill out. If they're wanting it in duplicate or triplicate, making sure that you're having that conversation with your local public health of kind of what the plan is, also talking about turnaround time, and giving guidance to the patient during the time as well of what they should be doing while waiting for results. So here is our current form that we are using for, and as I mentioned again, it's just critical if you think that you have a PUI, as soon as you're filling out the form, you're calling the local health department, they're walking you through it, and then making sure that you know what samples to collect. So specifically asking, report date, who's reporting it, is this an animal outbreak, date of onset of illness, what symptomology they have, has the patient been isolated. So they're going to ask you if they've come in from home, if they're isolating at home, or if they get discharged, if it's just mild and you're discharging them home, that you give them that education about self-isolation at home, or if they're being admitted into the hospital because of their flu-like symptoms or more severe, you're isolating them within the hospital and implementing good isolation practices, disinfection practices, compliant with PPE and hand hygiene for these patients. And then specifically asking them, have they come into contact on a farm in the last 10 days of onset? Have they traveled? Was the person tested for influenza? They're going to be asking you what type of influenza assay, what was the test result, have they taken antivirals, and then have they begun antiviral treatments for symptomology? So they'll be asking all of those things. And then lastly, for your contact trace on this form of what kind of animals were they in contact with, the location of the animals and the date, and then if they were under PPE during that time when they had contact with those specific animals. So when it's asking you for treatment, right now the recommendation treatment are antivirals and starting them immediately and not waiting for test results. And our big one is our Tamiflu. So giving patients Tamiflu, even if they've been sick for less than 2 days, or if it has been longer than 2 days before they're coming in and seeking treatment, that your provider is prescribing antiviral treatment to be given. With that note highlighted at the end that it should not be delayed while we're waiting laboratory testing. So if they're coming in with flu-like symptoms, we are prescribing Tamiflu. We're isolating them at home, or we're isolating them in the facility. We're putting them in good practices. And then for prevention of reducing the spread, so avoid how we can kind of work on this as a community, and then provide good patient education too of how we can keep ourselves safe, is avoid unprotected direct contact with a sick or ill animal. If we are around sick or ill animals, we're wearing appropriate PPE, and this is a lovely PPE visual that I found off the CDC. Link is right below it of what PPE that the CDC has recommended when working with farm animals to protect yourself against H5N1. You're performing hand hygiene. You're using appropriate disinfectants for EPA List M, which is more, again, your ammonia-based products as well. So we know what PPE to wear. We know how to disinfect. We know who to screen, specifically occupational. And then once we're looking at all of those, then we're isolating them as well. If any healthcare provider has seen a patient and then reports the next day or later that day that, hey, I wasn't wearing PPE when I saw them, that you're referring to your specific protocol and policy within your organization of how to isolate them, if we're having them go home on quarantine or not, but definitely looking at your organization system of what the next steps are, especially if they are starting to develop flu-like symptoms. CDC recommends that they are isolated, they're leaving work, and then they're seeking medical evaluation as well. But again, make sure that you're referring to your organization policy and procedure about exposure with your specific providers. So I know that was kind of a lot of information, and we could go into so much more, but I just wanted to give you some highlights of the last couple years of emerging pathogens, what the current forms are, so you have it being able to access it in one location with our person under investigation, our PUI forms. And having all this information, knowing who to screen, who to look for, educating your healthcare organization and providers is really critical in preventing cluster events and outbreak events in your facility and in the community. Having really good screening criteria and protocols and knowing exactly what to ask and who to screen really is the most effective way to reduce these pathogen spread. And definitely having good communication with your specific infection prevention department, with occupational health, within your organization, making sure all your providers know exactly what to ask, who to look for, what are the symptomologies, is really key in decreasing transmission. And then also communicating to your facilities, staff, your environment services, your staff as well so that they know, hey, it needs to be disinfected a certain way. We need to take extra time with this, and really ensuring that our good infection prevention and control practices are being maintained, the right chemicals are being used with the right wet time to really effectively kill and prevent transmission of these specific pathogens. So now we're going to ask you to scan the QR code, and we're going to go through our learning check activity on the 3 different pathogens I covered today. So I'll give you all a second to scan the QR code. And it's just a quick 10-question survey to really see how much you obtained from this lecture. All right, we'll start with the first question. Question 1, what type of rash is present for an Mpox diagnosis? And we encourage you guys to definitely put your answers in the chat too. I know you have it on the QPro quiz, but also put it in the chat so that we can talk about it. Yes, that is correct. D, it's all of these different types of rashes depending on the timeline they might be presenting. So you want to make sure that you are looking at all the different presentations of the rash. 2, what list for EPA disinfectant should be used for Mpox? Is it K, L, Q, or S? Yes, it's Q. Q is what we want to be using. Great C. Question 3, how do we obtain treatment? Can we write a prescription? Do we use the CDC EA-IND protocol, or do we go through the STOMP initiative? Yes, that is correct, C. We definitely cannot have a provider for a prescription that has not been approved. We go to those 2 different clinical setups to obtain treatment. 4, now we're going to go into Candida auris. How is Candida auris transmitted? Is it person to person? Is it airborne, contaminated food, or insect bite? Yes, that is correct. A, person to person contact. B, what class of drugs are used to provide treatment for Candida auris infection? Is it our antibiotics, antivirals, antifungals, or steroids? Yes, great. The answer is C, or antifungal. Since this is a fungus, it's a yeast. Question 6, what method is used to screen for Candida auris? Is it a blood test, a throat, a urine sample, or a composite sample? Great, excellent. Yes, D, it's a composite sample. Question 7, now going into H5N1. How is H5N1 transmitted? Is it birds, cows, human to human, or all above? Yes, it's D, all the above. Question 8, when collecting past medical information for H5N1 PUI person under investigation, which of the following should we ask? Travel history, occupational history, ill contact history, or D, all the above? Yes, D, we want to know where they were, occupationally, who they are, ill contacts, and then also including ill animals, making sure that you're asking them, have you come into contact with any ill animals in the last 10 days, as we saw on that PUI form. Question 9, if I want to obtain a laboratory test for a PUI, how do I do that? Do I contact my local or state health department? Do I put an order for our local laboratory? Do we use third party, or do we call the infection prevention department? Yes, it's our local and state health department. Since there's no commercially available assays yet for this emerging pathogen, You will need to call them, get permission to set in. Also, it's a great way to confirm that we have the right swabs, the right transport media, and just kind of really working in a collaboration so that we don't have a cluster event and that we're identifying this potential PUI. And then lastly, it is important to be informed on tracking infectious disease pathogen. True or false? Yeah, true. It's very important to make sure that you keep informed and start tracking these, especially in your facility. It's great to have a tracking system of potential rule outs, especially in emerging infectious diseases, in case later the patient comes back in, or maybe we test it as more information comes about that we tested them too early for this emerging pathogen. Maybe their symptom onset wasn't notified, like for Mpox, maybe that their threshold for the wasn't low enough. You know, they came in on day 1 instead of day 2, so they didn't have enough in viral component or particulates within the sample to be able to test on a diagnosis. Kind of like how we saw with COVID, that some pathogens have a specific window period that you can test too early and get a false negative test result, and then you give it a little bit longer, and then a day or two that they return, their symptoms are worse, you test them again, they are now positive. It's great to track them, explicitly to know later if now they're positive, if later you have to do a contact trace or an outbreak event, and follow up with the healthcare providers to ensure that they were wearing proper PPE when they saw them on their first visit. It's really helpful that you're tracking these infections in these rule out ways. So either building that in your EMR, your Tableau dashboards, asking, you know, your EMR specialist or your bioinformatics team to help build something to track emerging infectious diseases is great. Or you can always, if you don't have a lot of resources, you can always go to a spreadsheet of saying, you know, this patient with their patient identification came out this date, these are symptomologies, they were tested, these are the test results, they were negative, they were discharged home. So just some level of tracking is really great for these emerging pathogens. So here are all the correct answers. And then before we open up for questions, I'll just invite all of you to connect with us. Here is our IPC email. You can always email your questions specifically for us if there's more information that you're wanting on something. Again, I will repeat that the slide deck will be sent out within a week along with the video of today's presentation. Yes, the slide deck will be sent out in a week along with a copy of today's recorded lecture for your reference. You can look at all the PUI forms. With that, other general inquiries can be made to about TEPHI on our info at tephi.texas.gov. We have our couple QR codes through our webinar series that we do monthly of different topics, and then in general other TEPHI modules that you might want to look out, especially our ground rounds. They go over specific pathogens. Dr. Louise Ostrowski has presented on C. auris before, back in May. That lecture is recorded, so if you're wanting more specific information on C. auris, that's a great resource. Our next module that we will be having will be August 1. We will be going over an outbreak investigation, specifically looking at all the steps of the initial and post outbreak, going through and then kind of doing an example with a learning activity as well, of giving a scenario of a potential outbreak, what you should do, how to handle it, going for a next. We ask you all to complete this post-survey evaluation with the QR code here that really just asks your feedback about these modules, specifically on the clarity, consistency, benefit of information that we're providing you. This really helps us build future modules of how to really give the information better and making sure that we are delivering the material and it is effective. So we ask that you complete this. If you do complete this, your name will be entered into win some TEPHI swag that we will have mailed out to you as an appreciative and a thank you for completing the survey. And then just one last announcement, TEPHI has an annual summit that happens every year. This year it will be September 25th. And it will host a wide range of topics from livestock, food safety, and other things that will be discussed as well. So it is a free event that we will be hosting in September. There should be a registration link sent out in an email form or on a email notification blast in the future. So be on the way to look at that. You can do virtually or attend in person with address below here in Houston. And then lastly, as I mentioned in the beginning, this lecture is approved for a CPH credit or a CIC credit. Our previous modules listed here have been approved for those credits. You can go to your IPC dashboard to go through the credentialing process of obtaining your certificates specifically for those modules. So thank you for attending today. Here's the instructions how to go to your to build your platform that you can go into and obtain your certificates so that you can submit for your CPH renewal or your CIC renewal as documentation for that 1 hour of continuing education. And I just want to say thank you for all attending. Here's our resources. Here's more specific resources and references on Mpox as well. So I just want to say thank you. And then now I will open it up for questions. So for the first question, Mpox normally on the feet. So it can be anywhere on the body, sometimes on the foot. But as I mentioned, and when we went through the PUI form, it can really be all over. So don't just focus on the feet. Do a skin assessment from head to toe on patients that you're potentially ruling out for Mpox. For screening of C. auris patients with indwelling catheters, should those be counted as clinical cases or still be colonized? I mean, it really depends. I mean, the catheter is not the reason why that they have C. auris. The indwelling catheter is probably going to be low renal function, maybe urinary retention, other issues, unless they had a very colonized invasive infection that led to potential urogenital dysfunction. That would be a great question for your provider. If you don't know, ask the provider. They should know. They're taking care of the patient. They should be able to ask, answer your questions about, do you think that this is more colonization? Most likely it'll be colonization versus active infection. Active infection is that they're having new onset of symptomology, and that we're primary treating the Candida infection, and it's not that they're here for something else and they're colonized with Candida. So if it's in the differential of active versus colonization, if you're not sure, if it's not in the notes, definitely asking the provider for clarification so that you have proper documentation when you're submitting it to local public health. For Candida auris, for respiratory procedures, it's always, I always like to go up, especially if they are vented anytime with certain secretions. Going up through your N95 or your PAPR is always best recommended. I mean, you can always wear a mask, but because of, I guess it really depends for that, how you want to do it. I always prefer N95 or PAPR, especially with an emerging infectious disease pathogen, because it is so hard to kill and treat. But that's my personal preference. But you can drill down into the CDC recommendations for that. They might, they usually side with caution and always go up, just like we saw with Mpox and with H5N1. They were saying NIAGE, PAPR, and 95 for those specific patients. So the survey is back on the screen. For the RN, we're working on that. That's more to come maybe later, specifically under that, but right now it is just approved for public health professionals and infection prevention professionals. And then anyone that needs to go back to the different slides, so I can scroll back right here, your post-survey evaluation. And then these are the steps. And again, you will get the slide deck within a week that will have these steps that you can reference to how to go back and to obtain your CEs for your CPH or your CIC. And then the last question, the current prevalence, I do not know. That's a great question. I know a couple weeks ago, I was on a Region 5, Region 6 for Harris County call about where we've seen, at least in the Houston area, a huge uptake from before it was like 6 cases to now 12 cases going forward with that. I reached out to the health department this week to ask, but because of the terrible weather and the hurricane that we had here in Houston, I'm not sure. I did not receive a response, but that is very interesting. But no, I don't. I do not know at this time. All right. Well, if there's no other questions, I just want to thank you. Let me just scroll back up. Whoever is raising your hand, if you just want to put your question in the chat, I'm more than happy to answer it. But I just want to thank everyone for attending today. I know it's been, especially in the Houston area and the Gulf Coast region, it's been a very difficult time. So I hope you all are staying safe during the bad weather and the aftermath, and making sure if you are out cleaning up with debris, that making sure that you're wearing a mask so that we don't have an environmental exposures. And I wish you all the best and just safety during this time. Okay, great. Raising the hand was an accident. No, you're fine. Just wanted to make sure that you got your question answered. But thank you so much for everything. If you have questions, please reach out to us. More than happy to talk some more. And just thank you again, and hopefully see you at next month's module.